Who is starting?
Mala will start.
Will you perhaps just give me the go-ahead when I should begin?
Please go ahead.
Yes, Mala, please start with your video.
Hello, can you see me?
Yes.
Perfect. Do you think I can begin with the welcome? Hello?
Go ahead, Ms. Mala. We were live and
Sorry, can you hear me?
Mala, we can hear you. You can start.
Okay, perfect. Good morning to all. I just would like to extend a very, very warm welcome to everybody to the eSPACE Symposium, which has been organized between the eSPACE, which has been organized by Sun Pharma. This falls under our umbrella of eSPACE and is organized literally with between the Asian Institute of Gastroenterology in South Africa or in India, and then the South African Gastroenterology Society. It is brought to you with the compliments of Sun Pharma. This program is a culmination of the endeavor to integrate evidence-based medicine in clinical practice in the area of gastroenterology. Due to the fact that there's been tremendous progress in this field of GI endoscopy over the last few years, and the fact that eSPACE aims to incorporate this into in a dynamic way, the very best of its capacity every year. This is the reason behind us wanting to integrate and to roll out a program like this. So with most of the learning points illustrated from the point of view of everyday or day-to-day practice, this is actually what eSPACE promises you. And we promise you a very highly interactive and a very practice-orientated program today. So I once again welcome you to this program with all of the valuable speakers that we have. Just reiterating that Sun Pharma has always valued strong commitment in terms of disseminating scientific information. We live by the ethos of reaching people and touching lives, hoping that this program is going to meet your expectations from an academic perspective and that this will be a fruitful event for you to participate in. Without further ado, I'm going to hand over to Professor Adam Mohammed, the head of SAGES.
Good morning, everyone. It's with great honor and pleasure and humility that I get to be part of this process. As president of SAGES, a warm welcome to the Asian Institute of Gastroenterology, as well as to Sun Pharma, engaging and bringing the societies together. And I hope it's going to lead lots of interactions in the future. And I'm personally humbled by us having an opportunity to have one of the eminent, in my opinion, the #1 gastroenterologist in the world. TV goes so long that we probably won't have an hour and a half for me to go through it, but his fellowships in over 10 different societies. But I want to highlight, and just bear with me, highlight two aspects. He's a fellow of the American Association for the Advancement of Science, been awarded. He's been awarded the Rudolf Schindler Award, which is the highest award in the world for gastroendoscopy that's given out by the ASG. And it's with great honor that I have the opportunity to present Dr. Reddy, who can all learn from, and he's going to share with us one of his fields of interest amongst, I don't know how many expertise he has, but it's a real honor, and he's going to take us through the first topic of the duodenum. Thank you so much, Dr. Reddy.
Thank you very much. Thank you for that very kind introduction. I think I'll start my talk now. Here we can start the talk. Good morning, and I'd like to welcome all the members of the South African Gastroenterology Society for this eSPACE program. The SPACE program was actually conceptualized by Asian Institute of Gastroenterology and the Sun Pharmaceuticals to have a single theme-based masterclasses lasting for 1 to 1.5 days. These masterclasses have very practical lectures followed by live demonstrations and hands-on the animal lab. Because of the COVID, of course, we are not having the animal lab, but we'll continue to have these didactic lectures and, of course, live demonstrations. For this theme for this SPACE program is going to be metabolic endoscopy. There's been dramatic advances in treating patients with obesity and metabolic syndrome with new knowledge that has come from this. And what I'm going to do in the first lecture is to talk about how our whole thinking of the metabolic control has changed completely. This will be followed by a lecture by Dr. Rakesh on bariatric endoscopy, especially in diabetics and with obesity. And of course, ethics in medical practice by Dr. P.N. Rao, followed by live demonstration of both endoscopic suturing for a patient with obesity and of course a balloon, which is a temporary method to control obesity. So this would be the flow of how things would occur, and of course we welcome all questions from our colleagues there in South Africa. Now let me start first with the metabolic control of the duodenum. We know that the so-called metabolic syndrome, the term has changed now from NAFLD to MAFLD, meaning metabolic associated fatty liver disease. The whole metabolic syndrome of obesity, fatty liver disease, hypertriglyceridemia is all related to insulin resistance. And our belief has been that insulin resistance and control of glucose metabolism for all these years, that it was the pancreas which was controlling glucose metabolism. But this concept now we know is wrong. The actual metabolic control actually rests in the duodenum, the second, third, and fourth part of the duodenum. This is natural if you think of how we evolved as hunter-gatherers, that the food first comes in contact with the second, third, and fourth part of the duodenum, and this is where the control should normally exist. So let me just show you the concept that's building up now, that normally when we take food, as it passes partially digested to the second, third, and fourth part of the duodenum, it actually simulates certain incretins and anti-incretins. These are hormones situated in the second and third part of the duodenum, fourth part of the duodenum, and these incretins and anti-incretins actually maintain the body's euglycemia. The term anti-incretins is now being replaced by either insulin resistance factor or diabetic intestinal peptide. So because of equal concentrations of incretins and the insulin resistance factor, we have euglycemia. But see what happens now, because of civilizations, the food has become more refined. We now tend to eat this very high refined food. And when you tend to eat this very high refined food, the insulin resistant factor increases. The reason this happens is, if you don't have an increased insulin resistance factor, you can have a sudden dip in blood sugar levels, resulting in dangerous hypoglycemia. And of course, brain doesn't want this dangerous hypoglycemia. So over a period of time, hypoplastic enteroendocrine cells in the second, third, and fourth part of the duodenum have resulted in increased insulin resistance factor being secreted, and that results in insulin resistance. It also results in increased blood sugar, increased triglycerides, and of course the so-called NASH and other conditions. There's been a lot of work in this area, and there's several labs all over the world who are working in the hormonal status of the duodenum. The enteroendocrine cells of the duodenum are studied now very well. They are known to secrete a variety of hormones, including the GLP-1 and GLP-1 analogs, and so on. I don't want to go into the details of this because this is a separate chapter, but what ultimately results from this is that the brain gets enough amount of sugar so that it can function normally. The glucose production in the liver is controlled, the amount going in and coming out, and of course the glucose that's taken up by the muscles, and what happens in the circulating bloodstream is all controlled by these metabolic factors in the duodenum. Now, what is the proof for this? There are several proofs we have for this. First is that if you actually take biopsies from the duodenum of normal humans with euglycemia, you will find a certain concentration of enteroendocrine cells. But if you take biopsies from type 2 diabetic patients, you'll find a markedly increased enteroendocrine population, and of course certain degree of population which actually is secreting all these anti-incretins. We also have similar evidence from rats which have been fed on Western chow, and then you see that the endoendocrine population of the cells in the duodenum markedly increases. Now, this is a study which showed that if you have westernized diet given to mice for a long period of time, this focal duodenal hyperplasia resulting in insulin resistance. And actually, if you look at the duodenal mucosa in these rats, the chromogranin A markedly increases after a certain period of time. Further evidence came from these experiments, very elegant experiments by Rubino in the GK rats. Now, GK rats are spontaneously diabetic rats. They are born diabetic. And what happens is that when we try and do experiments on them, we can show how we can decrease or actually increase diabetes in these rats. So this was an experiment where across the duodenum of the rat, there were two types of tubes. One was a completely covered tube which was put in, and second was a fenestrated tube. And food was allowed to pass through. Now, in the completely covered tube, the food went through this into the distal part of the jejunum. Whereas in the fenestrated tube, the food went through, but some amount of food still had contact with the duodenal mucosa. And look at what the results are. The results are that in rats who had a completely covered tube and food was not exposed to the duodenum, second, third, fourth part, had a completely normalized oral glucose tolerance test. Whereas rats who had fenestrated tubes and normal rats had an abnormal OTT, suggesting that even small amount of food in contact with the second, third and fourth part of the duodenum can result in an abnormal response to this glucose. And further experiments came again from Rubino's group, who showed that if you do a gastrojejunostomy in the rat and then also exclude the pylorus, then these rats diabetes improves. The same GK rats, the diabetes improve. But if you do a gastrojejunostomy but keep the pylorus open, most food goes through this, but some amount of food is going through the duodenum and the diabetes does not improve, showing that the food stimulating the duodenum is the actual source for insulin resistance. So we now know that based on this physiological data that there are incretins and anti-incretins which are in the duodenal mucosa. The anti-incretins, of course, is the insulin resistance factor. There is a lot of work which is trying to identify the actual peptide which is responsible for this, and this balance actually results in the euglycemia or the eumetabolics we see in normal humans. Actually, some of this data is quite old. In fact, we knew very long back from surgery in patients who are undergoing obesity-related surgery, the Roux-en-Y gastric bypass, you see. When these patients undergo Roux-en-Y gastric bypass, their weight reduction takes long, sometimes 2-3 months to occur, but immediately fourth day itself, you see, the blood glucose control is improving and the need for insulin comes down. In fact, some of these patients go into hypoglycemia in the fourth or fifth day, indicating that there's something in the duodenum which is actually controlling, and absence of food in the duodenum is responsible for this euglycemic state. And some very, very elegant human experiments were done by Cummings and his group, and let me show you this. These are patients who underwent Roux-en-Y gastric bypass for obesity, and what happens is they are normally hyperglycemic patients. They underwent RYGB, and when they undergo gastric bypass and you feed them normally, the food goes through the jejunum, bypassing the duodenum, and these patients become normoglycemic, right? Now, what they did is, after permission from the ethical committee, they introduced a gastrostomy tube in the second week in these patients, a feeding gastrostomy tube, and started feeding through gastrostomy. So when they started feeding through gastrostomy, the food was not only going through the mouth, bypassing the duodenum, but small amount of food was actually going through the duodenum also. And when they looked at these patients, they again became hyperglycemic. So normoglycemic patients became hypoglycemic when the food started passing through the second, third part of the duodenum. And when they took out this tube again and then started feeding, again these patients became normoglycemic. A very, very clear indication that the food stimulating the duodenum actually causes secretion of an insulin resistance factor, which is responsible for hyperglycemia. So duodenal nutrients passage strongly influences insulin sensitivity, and this is independent of weight change. This is a true metabolic change in our body. Some of this also was displayed in this work which came with endobarrier. Endobarrier was a sleeve that was used to decrease the weight actually started in South Africa, South America, sorry, where these endobarrier tubes were put in, and people started losing weight because of malabsorption, food going to the duodenum. But what was surprising was not only was weight loss there, but these patients started having better glucose control. In fact, the weight loss was marginal, maybe 5%, but the glucose control was dramatic. But unfortunately, with these tubes which were used, there was barbs to attach the end of the tube to the duodenum, and this produced portal pyemia and portal and liver abscesses, and of course these were banned. Subsequently, we tried doing other things with these tubes. In fact, our group here, working with another group in US, actually made another type of sleeve which had a special type of stent to anchor this. So this sleeve could be anchored without the barbs. And we found when this was done, and these tubes can be taken out after 6 months. And during this 6 months period, the patient's metabolic control became very easy. Many of them did not have to use insulin. Oral hypoglycemic agents was completely decreased and so on. But the unfortunate thing with this, of course, is that when you remove these sleeves, their metabolic control goes off again. And you can see this very clearly from the study from Netherlands, that when the tubes are removed, again they become hyperglycemic. And therefore, we required something more permanent. And this permanent came from these studies. And this was a study which was done, a multicentric study from a group from UK, Belgium, and South America. The concept of this was that because the duodenal mucosa has control of the metabolic problems, if we remove the duodenal mucosa and a new duodenal mucosa comes, can the metabolic control be better? So based on this, they again took these GK rats, and the duodenal mucosa was scraped using this special brush. And after the new duodenal mucosa grew, they found that the new duodenal mucosa did not have the same characteristics of the old one. The new one had less enteroendocrine cells. The new GK rats became normoglycemic from diabetic rats. So this was a very interesting concept. And you can see this very clearly that after abrasion, the oral glucose tolerance tests were better controlled. They extended this study to a larger animal, the swine, where they injected saline under the submucosa to lift the mucosa, not to injure the layers below. And after lifting the submucosa, they burnt the mucosa completely. And on burning the mucosa completely, the new mucosa which came was totally different and had better metabolic control. So based on this, the concept of duodenal mucosal resurfacing procedure came in, a procedure which was actually popularized by Dr. Jack David and his unit in Erasmus in Brussels. So what is done in this is a hot water balloon is used, the submucosa is injected, the mucosa is lifted up, and the hot water balloon with 80 degrees centigrade is put on the mucosa. And this is done from second, third, and fourth part of the duodenum to completely ablate the mucosa. So this is a hydrodermal ablation that is taking place. And you can see what happens to the mucosa. As soon as it's ablated, it becomes ischemic, shows some ulceration type of thing. But by 3 months, the mucosa is completely regenerated again. The newer balloon which has come is much easier to use. It simultaneously injects and also lifts up the mucosa. You see, this is the point, the papilla, where a clip is being placed so that we know where to start this ablation process. And once this balloon is inflated, we can simultaneously inject and use the same balloon for hydrothermal injury. And this is quite easy to do. The procedure which takes about half an hour to 45 minutes to complete, producing total thermal damage to the duodenal mucosa. This is a safe procedure. Over 300 procedures have been done now, with only 2 patients having some mild strictures which were treated endoscopically. So there's no major complications. There have been several studies done with this duodenal mucosal resurfacing. So starting from Revita 1, which is a proof of concept study, show that it works. Revita 2 was a sham control study. 2 groups, one had Revita done and one did not have it done. And the other is the eSPACE study, which looked at insulin resistance, and of course the NASH study, which is being done in Erasmus, where they have done paired liver biopsies before and after duodenal mucosal resurfacing to show that the liver fat goes off, the fibrosis actually reverses. And the Domino study, which is in polycystic ovarian syndrome, which has a similar basis of the metabolic syndrome. Now let's look at this Revita one. You can see that there's a fairly dramatic glycemic improvement, which is up to 1.2 A1C changes, which is quite remarkable considering that most of the powerful drugs will only do this. And the study was published in the Gut with all the details, and you can see that insulin resistance comes down. The weight doesn't come down so much, only about 5 kg, but it's predominantly the insulin resistance. And there's also a quite dramatic improvement in liver enzymes. Both AST and ALT come down from their basal levels. And this is one of the observations that was made from the study, which encouraged these researchers to study more the metabolic process, including the NASH, where the NASH can be reversed. This was a study from Dutch group who actually used DMR to see if you can take out these patients from insulin usage. So you can 16 patients, 6 months, you can see that 69% were off insulin therapy, even after 6 months. A1Cs came down. After 12 months, more than half the patients, even after 2 years, around half the patients were off insulin when this therapy was done. I think this is very, very good news for diabetics. And this was, again, a study from this group, which was a multicentric study from different Netherlands, Brussels, South America, and so on. And you can see that what they found is that using DMR, you not only reduced glycemia, A1C was reduced by 1.5, improved all the liver parameters. You can see ALT improved, AST improved, and so on. And fibrosis dramatically reversed. Insulin resistance came down, and also anti-inflammatory capacities came down, antioxidant capacity increased. So the whole metabolic process was completely reversed using this DMR technique. And I think this is very exciting news, because we finally know that where the control for the metabolic process. And most interestingly in these patients, especially if you look at what happened to the liver NASH, not only was there decreased inflammation, this could be a combination of anti-inflammatory, antioxidants, and so on, but in some of these patients where a paired biopsy was done, there was also a reduction in fibrosis. And this is, I think, good news, and further studies in this area are going on. So I think we now know that the duodenum has a major role in the metabolic process in the body. It has a physiological role which came because of the hunter-gatherer, because of the evolutionary process. There is evidence that pathophysiology, like hypoplasia of the upper GI exposed to excess fat and so on, can give rise to an abnormal enteroendocrine population, and that this signal, which results in insulin resistance, can be interrupted by both surgery, which is in form of Roux-en-Y gastric bypass, endoluminal sleeves, which have a temporary effect, but also by hydrothermal ablation, which has a more permanent effect. I think this is very exciting news, and I think finally we have an answer how to deal with the metabolic syndrome in our patients. And this seems to be a simple endoscope with an access to the second, third, and fourth part of the duodenum. Thank you very much for your attention. We'll go on to the questions, and of course afterwards Dr. Rakesh is going to talk on the use of endoscopy, not only for this metabolic but also for bariatrics as such.
Thank you so much, Dr. Reddy. That was really invigorating. I thought I was back at medical school, doing a lot of physiology, and I'm saying, my God, where's the endoscopy coming? Just for the audience out there, please use the chat facility on the YouTube to post some questions, and we could get it to Dr. Reddy. If it takes a little while to come through, we'll actually ask it later on, because he will be with us with this seminar as well. My question to Dr. Reddy, while we're waiting for any questions, to come up, is poor outcomes with the duodenal sleeve that had such amazing success in South America somehow didn't get vogue in North America. And it was, you used the Revita trial, and there were two adverse events. I don't think there were many adverse events with the duodenal sleeve of South America. Why are we not still pursuing that? Because that seems to be the best option for a short course of intensive loss of weight.
So that's a good question. But actually the problem is several things. First of all, when you use the sleeve, it's a temporary effect. It acts only for 3 to 6 months when you keep the sleeve. Soon as you remove the sleeve, we find that the metabolic process comes back because you're not changing the mucosa. You're just temporarily halting the food interacting with the duodenum. So it's very temporary. But two, sleeve was actually designed for obesity, but what we found when we started using the sleeve is that the weight loss with sleeve was marginal. It's only about 5% total weight, which wasn't as good as, say, bariatric procedures, either surgical or endoscopic. So it was a marginal weight loss. It was temporary in nature. Mostly the effect was metabolic. So that's the reason why sleeve was not a major role in obesity. What happened in, although South America had a good experience in North America, the sleeve was used often. These hepatic abscesses were discovered. Liver abscess occurred because the sleeve barbs are put into the duodenum. There's portal pyemia infection and liver abscesses. The FDA came down very heavily on this and banned the use of sleeve. The reason why this barrier was no longer available, and just now recently they modified it, going to become available for study. This was a major problem. But even if the endobarrier or any other sleeve is available, I don't think it will be a major fight against obesity with it. You have to use it more for metabolic purposes, to say for diabetes and not for the actual obesity. Obesity is pathophysiological.
From a question from Dr. Siabi, and this would probably be the last question because I don't want us running out of time, is how many DMR sessions would a patient require for long-term glycemic control?
So generally, one DMR gives glycemic control for about 2 years. The data we have now is up to 2 years. We believe that as we look at the graphs of what is happening, after 2 years, there may be a slight increase in sugar levels or the A1C levels, and we can repeat the DMR again after 2 years. So my feeling is that once DMR gets into commercial use, we might be repeating it once in 2 or 3 years based upon metabolic control.
Thank you so much, Dr. Reddy. I don't see any more questions on the chat. So what I'm going to do now is just introduce the next chair from SAGES, who is Professor Jonas, who's from the University of Cape Town, who has a strong obesity surgery background as well as transplantation background. And I think there's a big overlap in those fields coming to most centers nowadays. And he will be representing SAGES. It will give me great honor to introduce our next speaker, Dr. Rakesh Kalpala, consultant and director for the Center for Obesity and Metabolic Therapy at AIG Hospitals. Again, an amazing CEO with lots of clinical and publication and acknowledgement by many many memberships and affiliations across the world. But just to highlight, relevant to this topic, is endobariatric procedures in focus, intragastric balloons, endoscopic sleeve gastroplasty, vaginal bypass liners, endoluminal vertical gastroplasty. With great honor that I welcome Rakesh to give us a talk on his focus on obesity. And thank you so much. Please
Mohammed,
remember
sorry.
to try.
Just a second. I think I just saw in the chat box one important question. So before you go to the next lecture, I'll just quickly go through that. This is Dr. Onathan Bolan has asked whether the access the third and fourth part of the duodenum, you can do it with a standard gastroscope or an enteroscope. You do it with standard gastroscope, but if you have a standard gastroscope with a therapeutic channel more than 3.2, then it's much easier to pass this, the guide wire sensor. So you can do it with a standard gastroscope. You don't require a special gastroscope or an enteroscope to do this procedure of Sorry for interrupting.
No, that was a very good question. Thank you so much, Dr. Reddy, for jumping in. So I'd just like to ask Dr. Rakesh to take over and present his talk. Thank you so much, and Dr. Jonas will take over as well.
Thank you, and thanks for the kind introduction. Morning, so just share my screen. Dr. Reddy has given an overview of what happens in the duodenum metabolic control. Now, it's fairly a huge topic to cover on in this short time, but I'll try to cover it. So what's happening in the field of bariatric endoscopy in terms of diabetes and diabetes? So let me start. As you see here, can you see my screen there? My screen is visible.
Oh,
Is my screen visible there, my slides? Okay. So if you see the various therapies in endoscopic field in terms of diabetes and obesity, primarily they're divided into two: the gastric devices, gastric remodeling techniques, and the small bowel remodeling, which Reddy has touched upon. So as you see here, the gastric remodeling techniques or gastric metabolic and bariatric endoscopy were gaining weight loss with metabolic effects dependent on that. Whereas vis-a-vis in small bowel, we have metabolic effects independent of weight loss, but some weight loss might be seen concomitantly. This is the basic scenario on endoscopic methods pertaining to stomach and small. As you see here in the interventions in the stomach, to start with, there are few of the FDA approved devices. There are few which are in the pipeline. There are few which are CE marked also. So space occupying devices primarily are the balloons, and you have transpyloric shuttle, and also the full sense, which is again a device going to be patented by our group. I'll show you in the next. It's what it means. So balloons or the intragastric space occupying devices, they can be either air filled or liquid filled. So you all might have seen the liquid filled balloons. Few of them must have having their own experience, which cause weight loss in 6 months to 12 months. And typically in most of the meta-analysis published, they have shown around 6 to 12% weight loss in various. So these are the balloons which are there in the market: the Orbera balloon from the Apollo Endosurgery, Obalon, Reshape, and so on. Orbera balloon is typically the old class balloon, which few of you might have having their own experience. I'll just show you what is there in the pipeline in the future. So this is one balloon from a company called Obalon, which is FDA approved. So this is just on an OPD basis, an outpatient in your office. The patient can ingest the capsule. Then once the capsule gets into the stomach, reacts with the gastric mucosa and the juice there, and then it swells up. It's a nitrogen gas mixture where 3 capsules are followed simultaneously, one after the other. And then after 6 months, when you achieve the desired weight loss, they are removed endoscopy. So this is the future. I mean, it is still there in the market. Of course, it hasn't penetrated into the other markets of the world, but FDA has approved, and it is. So again, now the question comes, why again endoscopy? Can you do something without endoscopy, where the patient comes in, ingests the balloon, and then goes out? And after a few months, the balloon will come out of your fecal matter. So look at this animation. So this is the ellipse balloon, which is there in the market now. It's again due for approvals from FDA and CE. As you see here, patient ingests the capsule, it gets inside, reacts to the gastric juice, it swells up, and then the twig is removed. After that, once the patient starts eating, then over a period of 3 to 6 months, there'll be obviously decrease in the gastric volume and accommodation, and they cannot eat more. And you achieve the desired weight loss in 6 months. And after 6 months, what happens is something which is beautiful. So the balloon disintegrates on its own and then gets into the small bowel and then the large bowel, and then it passes in the fecal. So it's really an amazing thing which we are all looking forward. And probably the patient might not come to a doctor and then can just go to the market, buy it and then just consume. This is one thing which is the future of obesity weight loss. So SPARS balloon is a newer generation balloon, which we'll be showing it in the live workshop in the next 1 hour. So the advantage of this balloon over the existing balloons is it's got a twig, a tag, which is easily amenable, and then you can take out the balloon, you can ingest more volume, or you can take out some volume if at all the patient is not having that. So the advantage of this balloon over the existing balloons is there is one study which has been showed in patients for weight loss as well as in patients for NAFLD, where they found a significant improvement in the weight loss compared to the existing standard balloon. So with this, we also we started a clinical study at our institute where we have taken this adjustable intragastric balloon in obese patients between BMI of 30 to 40 with NASH or NAFLD. And then we have done biopsies pre and post with US-guided liver biopsies to show improvement in fibrosis score after deployment of this balloon. And then we are in the process of studying this. We'll come up shortly with this. So this is one balloon which I personally feel is now the existing need of the hour, and then it is going to go long because one is the adjustability. Because you see most of the patients when they take in the balloon, second, third day, they come out, if they're very sensitive and say, doc, you just take out my balloon. But then you can convince them and then probably take out 50 to 100 ml out. And after 3 to 4 weeks, if the weight loss is not desired, then you can ingest more volume into that, where you can go up to 900 also. That's the advantage of the adjust. With the future of the balloons, again, is very interesting. As you see in the picture, there is a capsule which is made of this hydrogel. You ingest the capsule, and then once it gets into the stomach, it reacts with the gastric mucosa and the contents there, and the particles enlarge, and then they occupy around 40 to 50% of the stomach, where once you eat that, so this is supposed to be taken 10 to 15 minutes before your meal. You ingest this, that will occupy 50% of your stomach. Then you start eating, and then obviously you will feel full, early satiety, because these gel capsules will occupy most of your stomach. And this can be taken thrice a day before the meal. And after half an hour around, the particles get dissolved, and then they get into the small intestine, then the large intestine. The cellulose part will be excreted in the feces, and the gel part will be excreted in the urine. So how fascinating is this? This is called Genesis 100 picture. 100. And this is one which is, again, probably going to be the future in the pipe. So that is about the space-occupying devices. Now the endoscopic gastric remodeling in the stomach. So you have this Apollo overstitch, then you have POSE, which is called primary obesity surgery endoluminal, and endomina. They are the three currently practiced stitching devices or the gastric remodeling devices in the market. And fortunately, we have all three available at our institute. Coming to Apollo overstitch, I don't touch upon in depth in this because we are going to have anyway a live case going to be demonstrated in the next workshop coming. So this is basically a overstitch device, which is a short video. I'll skip it because anyway you're going to see live. So the advantage of this, and the so far literature available, is a 2-year follow-up study from Lopez Nava from Spain, where they found a sustained weight loss of 15 to 18% up to 2 years. And then the Reem Sharaya group from Weill Cornell University, New York, have come with a 5-year follow-up where they have found the weight loss sustainable up to 14%. So adverse events, very minimal. I hardly see. We have around more than 100 plus cases experience in past couple of years, nausea, dyspepsia, and there are 1 or 2% cases of perigastric collections, which are against. Fortunately, we didn't have so. The second one is again a US, waiting for the US FDA approval, that is primary surgery obesity endoluminal. This again is a suturing device, but unlike the Apollo overstitch, it does islands of suturing, and then it will get the volume reduction of the stomach in the antrum and the body area. So this is one which has been done in one of our workshops. You see on the screen 2 gentlemen. One is Gontran Lopez Nava from Spain and Barham Abudai from Mayo Clinic, heads of respective departments. And then this is one live case which we have done in one of our workshops. And this, as you see on the screen, is islands of mucosa are picked up, and then you reduce the volume of stomach by mucosa in the gas. So the literature pertaining to POSE, there is a 12-month data which they have found 13% total body weight loss, and the follow-up is going on in different centers across Europe. And this is again endomina from Brussels. This is basically a patent from University of Erasmus, where Dr. Vincent Huberty and Dr. Jack Davies group have come up with this. And this is one also a very simple device of endoscopic suturing. As you see on the screen, the video being played, you have a forceps which will drag the mucosa inside these 2 towers, and then you apply the sutures. So that this is again very easy. In fact, we are fortunate to have a hands-on, and then now we have a multi-center study with 15 centers in Europe and 1 center in India, where we started working on this endomina device. we picked up patients with NAFLD or NASH, then did this endoscopic suturing. Post suturing within 6 months, we have done biopsies pre and post on liver. And then we are going to soon start this multi-center study. Then we'll be waiting for this result. But they have a study which is being followed up from past 1 year or more on the standalone obese patients, where they found around 7 to 10% weight loss. So if you compare the endoscopic sleeve gastroplasty versus laparoscopic sleeve gastrectomy, where surgical bariatric surgeon there in the panel. So there is one publication in GI endoscopy from Johns Hopkins group, where they have found equal efficacy and of course less morbidity because it's minimally invasive kind of a. So the future of gastric remodeling. So you see, this is very fascinating. EndoZip. So why you have to unnecessarily waste your time and energy by doing stitching on your own manual? So a group from Israel have come up with a device called EndoZip, where it is a fully automated, operator-independent endoscopic suturing. And I'll just show you a short animation of how it looks. So this is an inbuilt device which has got scope with the suturing device. This is an animation where the device goes in and then it will start drawing the tissue of the stomach inside the suction ports, and then it will enable the apposition of either walls of the anterior and posterior walls of stomach. And then there will be a helical needle which rotates on its own and starts suturing like a sewing machine. Isn't it fascinating? So after the suture is done, the needle is removed from the system. Then you just drag the scope and the device out so that the sutures are intact. And probably what I have heard from colleague Lopez Nava in Spain, he has done human studies, it hardly takes 25 to 30. So that is about the suturing techniques in remodeling the stomach. So now this is one thing which I just wanted to you people to have a orientation on. As you see, in the gastric cardia, there are a lot of mechanical receptors which exert early satiety if you put pressure on that, localized force. With this concept, what we thought, there's a group from University of Michigan in USA. So they have come up with the concept of doing something like esophageal stent. So it's called a bariatric stent, which exerts pressure at the cardioreceptors, mechanical receptors, which leads to early satiety. So with this in mind, they started developing this implant, which has got a esophageal end and a gastric end, where the gastric cardia is covered by a disc, which exerts pressure on the gastric cardia, leading to early satiety. So there is a delivery system, which is inbuilt with a specific scope, the pediatric scope, which is used to deploy the. So they have done first in animal studies in Minnesota, and then they devised this. So after this, they have, with the help of the Mayo Clinic in USA, they approached us, and this is a controlled delivery system which is used. So you have the disc which is deployed automatically there. So as you see, this is a short video. We have done the first in human trials in the world initially, and the patient is intubated with general anesthesia. Then under endoscopic direct visualization, we have a pediatric scope which is mounted on the device of full sense. And as you see here, very simple 15 to 20 minutes procedure. You deploy the esophageal stent, and then to hold the stent without migrating, we use the Apollo overstitch and then suture 3 sutures on the proximal end of the esophageal stent, 2 on the distal end of the G. And then we leave the device for 6 months. So what we have seen in a short series is we have achieved a weight loss of around 15 to 20% in 3. And the device is well tolerable. Of course, after 6 months, you have to deploy it. And even the deployment also is pretty much easy. And in fact, the deployment can be done in, the extraction can be done in conscious sedation. So after 6 months, this is how it looks. There are a little bit of mucosa penetrating into the barbs of the stent, but again, these are all inflammatory. So what we do is we cut open the distal part of the gastric area with just a coagulation forceps. Then disc gets detached from the gastric end. Then you cut open the sutures at the proximal end with a simple Olympus scissors. and you just have to grasp the esophageal end of the stent with a lasso and then withdraw it out. It's as simple as that. So this is about the full sense. So they have done one first proof of concept study in Mexico, and then we took over the study. Now it has gone for investigation device exemption for the FDA approval, so that they can do a trial with the FDA norms. So this is the study design of this. So this is about the gastric remodeling techniques in terms of obesity, and of course, as I told you, indirectly they help in getting the diabetes. So now the interesting topic is about diabetes, obesity, and NAFLD or MAF. So I think probably I believe strongly that ethnic origin of Indians has got a lot of matching with the South Africans also about obesity and diabetes. And I'm not very sure about the prevalence of obesity and diabetes in your population, but it is like an epidemic as corona or COVID in Indian population. So we thought, let's do something in this diabetes and obesity and overlapping of fatty liver disease. So on this basis, as Dr. Reddy has elegantly told in the last lecture, in his previous lecture, I'll just touch upon few of them because he has already mentioned that. So you have the small bowel remodeling technique, small bowel therapies, where you have the bypass liners, then you have the mucosal ablation techniques, then you have the incisionless anastomosis, and also endoluminal bypass. So what happens is, again, because you have, he has described in depth about the physiology. So as you put the liners in the upper small intestine, these are the basic mechanisms what happen, where we have the increased plasma bile acids, and in the lower small intestine, there will be increased GLP-1 analogs and peptide YY secretion. So as he has told earlier, the endobarrier study has been withdrawn from the FDA because of this pyemic abscesses in the liver, which happened. So with this, we have come up with the endosleeve technique, and I'll just skip these slides because a repetition for you. I'll just show you the data, what has been done on endosleeve in our institute, the first in human trials in the world. As you see on the last column, we have achieved a HbA1c, the percentage of glycated hemoglobin control of 1.8% max, with a total body weight loss of 12.6 hot series. So the reason why we haven't gone a little bit more, or by this time we would have had a CE mark approval also, is because of the COVID. Last 1 year it was still. What we observed in this duodenal sleeve is, as you see on the screen here, the pyloro-duodenal channel is such a dynamic organ in the body that I feel personally that is the most dynamic organ of all the parts in the human body. And there are certain issues of migration which happened with this device. Because as you see here, once the food or the chyme gets into the pylorus and gets into duodenum, there is undue pressure on the stent device end. As you see here, there will be a little bit of folding of the axial force causing distal migration of the stent, which happened in our experience. So then we thought, let's do something on this so that we understand the basic physiology of pyloric sphincter. And then we used a endoflip technique, that is a functional luminal imaging probe. And we did a assessment of this pyloric sphincter physiology in healthy volunteers, because we were shocked when we had such a robust, thick stent getting migrated to the distal. And we found the baseline volume of healthy volunteers of how much they have diameter and the cross-sectional area at the pyloric channel. And we also gave hyoscine, right, to stimulate the contractions so that it will be more robust to design. So then we went back to the bench, and then what we did was, of course, one, we designed a duplication with a long overtube, which will directly sit in the pyloric opening and deploy the device. Otherwise, we used to take 15 minutes for this endosleeve to deploy, but now within 10 minutes, because of the long overtube, we could. And then to maintain the stent there without migration, we developed this suture tether delivery procedure, which I'll just show you in a short video, so that it will act as a T-tag, where the T-tag of one end will be on the pyloric side, one on the duodenal side, and then vis-a-vis you come down and then put the second T-tag. So this is one which will prevent the migration. Of course, after 6 months, once you achieve the desired weight loss and glycemic control, you just cut open the T-tag and then it will be. So this is one thing which we improved. and then we made it available now, of course, on the bench side. We did an animal study in Minneapolis where we found, fortunately, the device didn't migrate for 3. Probably the next 1 or 2 months, we'll be going on to the bedside, and then we'll do the second phase of human trials phase, hemodics device. Coming to the other very interesting futuristic thing, which is again there in the market but not approved by FDA or CE, is endoscopic jejunal ileal bypass and duodenal ileal bypass. This is very interesting. So you have 2 magnets which you put it from enteroscope from oral and colonoscope from aboral end, and then you reciprocate these octagonal magnets at the jejunal-ileal ends. As you see in this animation, 2 magnets coming at the jejunum and the ileum, and then you create a natural fistula which opens up with these 2 magnets on day 6 or day 7. And once they open up, then it will act as a ileal bypass, which surgeons do. So this is endoscopically can be achieved. And this is a dual path which you require 2 scopes and 2 operators to do. So this is again one area probably which will take a big leap in the area of diabesity once it gets into the work. And it's already a published article from Christopher Thompson group from Brigham, Massachusetts Hospital, where they have found a 1-year interim results having very promising. But of course, the company is working on, and something which we look upon near future in the field, especially in diabetes. Then you have this Valentex, of course, has taken a back leap because of some fund. You see, they're all like startups which will come forward, and then because of funds, they'll go back and they get. So Valentex has taken a significant leap in this, where unlike the duodenal-jejunal bypass lane, you have a gastro-duodenal-jejunal bypass lane. Is you will have the food bypass right from your GE junction. So there is one short study being published for this group, but again, Valentex is a little that they are working on for some permutations. And so gastro-duodenal jejunal bypass lane, this is a Valentex data which is published earlier. And now, as you have seen, the DMR technique, which is Dr. Reddy has mentioned, that is a heat technology. So heat technology, again, the question asked by one of the delegates is how far you can, how many times you can reproduce it. One thing what the studies have shown in the animal models is if you reproduce more with this heat technology where the hot water is used to ablate, they might go into a kind of a mitotic stage in the long run if you do it repeatedly, which is again a theoretical thing. So to overcome that, what people have done is to think on doing a non-heat technology, which is electroporation. So this is one thing, again, a future thing which we have to look upon. So with this in mind, people at Mayo, again, good friends of us and our close associates, AIG Mayo Group, so they have, Barham Abu Dhabi has started working on this, where they have a non-heat technology of electroporating the duodenal mucosa, so that one, it will not cause any pictures which are there in 1 to 2% of the DMR group which is published. Second, again, if you do it, reproduce it in a long run multiple times, you might not get any mitotic lesions in the long run. So with this, they started working on this, and then they have finished the animal model studies on the electroporation technique. Simultaneously, cardiac colleagues in Mayo also started doing this as electrophysiological studies for ablating the myocardium for arrhythmias. And now, in the next 2-3 months, electroporation is going to come in the first in human trials. I think probably we'll be also fortunate enough to start that trial along with one center in Australia and one. Of course, this is again the future what I am talking about. So the dual efficacy or effect of this duodenal bypass laners pertaining to small bowel is one, you have a good glycemic control achieved by 1.5 to 2% HbA1c drop, and there is no risk of any hypoglycemia with this. Second, you have a concomitant weight loss of around 12 to 13%, which again shown in many of the long run studies. And third, cardiometabolic improvement, where you have a significant reduction in your blood pressures, lipids, also improvement in your fatty liver. In fact, in our short series, we have found people with F2 or F3 borderline fibrosis coming back to F1 or even normal liver on biopsy. That is the beauty of this weight loss. Just to summarize, everybody take home message is it's a rule of 10. 10% weight loss is good enough to get into improvement on your diabetes, improvement on your obesity, improvement on your metabolic parameters. So one thing what we have to remember is if you achieve minimum of 10% weight loss, rule of 10, then that is good enough to get significant improvement in all these aspects of obesity, diabetes, syndrome. So the future lies in here, as I told you, the gastric component, small intestine component. If you combine both, then that is the future where probably we as endoscopists can give support to the bariatric surgeons, especially in BMI between 30 to 40, that's class 1 and class 2. Because class 3 obesity, we can do all these bariatric endoscopic procedures, provided the patient is not willing or they are not fit for surgery. But class 3, again, with due respect for our surgical colleagues, they are the first options in that. But again, bariatric endoscopy has got a place through and through, from overweight, class 1 obesity, class 2 obesity, and class 3 obesity. So if you combine both these modalities in endobariatrics, that is going to be the next decade evolving technology and innovations which will take care of diabetes. So with this, I'll conclude and be happy to take the questions. After this, we'll go on to the live workshop. Where, thank you.
Okay, thank you very much, Rakesh, for this fantastic lecture. Just a disclaimer, my bariatric career stopped 10 years ago on bypass, so I wasn't part of these fantastic developments. Really fascinating. We have got one question on the chat. Dr. Mustaf Mushin, is there any possibility of nutritional deficiency, endoscopic resurfacing?
Very good question. Actually, 1.5 to 2 years data is available right now from the European and US groups. They haven't shown any obvious nutritional deficiency, but there are a few anecdotal reports of B12 deficiency being documented. So probably you need to supplement that with those folks with B12.
I don't see any questions, but I would just like to ask, I don't see any questions, but I would just like to ask, so with the restrictive procedures as they both be past the things will be quite robust, but a lot of patients manage to eat their way through it with high sort of reoperation rates at that stage. Up, I think in our series it was about 25% that were converted eventually to gastric bypass. And having done endoscopies on these patients, it's actually quite frightening to see that the eating patterns actually can bypass those mechanisms, and you get band erosion and so forth. And I understand it's not only about the restrictive procedures here, it's sort of gastric remodeling. But one of my concerns were always is how, if these sort of quite robust bands do not do the job, how is mucosal procedures basically going to tolerate the eating patterns?
Yeah, that's right. So at the end of the day, I think probably see what the mucosal ablation procedures, they are all for people probably who are diabetic. But if it is a standalone obese or diabetes with obesity, as you said, at the end of the day, we have seen many people who have got sleeve gastrectomy done and then they have a regain of weight. In fact, we quite often do the suturing for the residual pouch and they gain weight. So that's again very important, psych and motivation. So that's the reason why we have a department who has got everything under one roof. We have a nutritionist, psychologist, physiotherapist, and we as doctors. So it's a holistic approach which needs to be given to the patient. And of course, the patient's mindset and willpower is very important at that.
I think we've got a
Hi, Prof. Jonas, can I ask a question to Rakesh?
Yep.
If we look at what's happening overseas, there's a big move now to cardiometabolic groups,
Yes.
not just, nephrologists or endocrinologists. It's been combined into clinics. And I think as a gastroenterologist, we're actually almost being left out, and it should be gastrometabolic rather than cardiometabolic. But I think it's coming to the stage where we know that obesity abdominal issues, GIT issues are all linked to cardiovascular, renal outcomes. If I'm putting my own personal bias there with liver disease. And liver and NAFL is the central thing of all of this here. So I think as a society, we have to start getting and moving into MDTs and becoming gastro-cardio-metabolic clinics. And I emphasize gastro at the first of all of those letters.
In fact, to add on to the point, if now the gut microbiome is taking a big leap in, so probably the epicenter for every disease is the gut microbiome. As gastroenterologists, we have got a big role in the next 2 decades.
Right, I think we've got another 2 minutes. I just want to ask you, there are some techniques described as well, embolization techniques, left gastric artery embolization. Do you think those in combination with these endoscopic, minimally invasive procedures is going to be a way forward, or can that contribute to the results?
Yeah, definitely. There's a group from US which has done the gastric embolization techniques. And as you said, if you have a good intervention radiologist backing you, so probably you can do that at the gastric level, and then kind of the ablative techniques or duodenal bypass lanes at the stomach, small intestine. That's again one area which you have to explore, and then which.
Right, and then I've got a bit of time left. From Wisdom Mudombi, is the ampulla not affected with a duodenal heat approach?
Sorry?
With a duodenal heat approach, is the ampulla not affected?
No, because the ablation is typically going to start beyond above the ampulla. And at 60 centimeters, roughly the ampulla comes, so you have to stop there. And you start from ampulla and come upward. So you don't, and then just even the bypass liners also, they are all made of poly Teflon ethylene material. So they don't really obstruct the ampulla. They're very soft. And they literally float in the small bowel.
Yeah. I mean, duodenal stenting isn't even covered in quite tight strictures. Is usually not a problem. Just another question here. EUS guided DJB, are there any contraindications?
Yeah, so US guided DJB is again one thing which is now being developed by some of the groups in Europe, where you do a US guided DJ fistulous opening with the axios stent, and then you put in a device which will make that stent to be patent there without migration. That is one which, in fact, the device is from Boston Scientific, and it is being experimented in Jack Davies group. So we are also looking forward for that. Again, a good idea.
Okay, thank you very much. I don't see any more questions here, and we're just on time, so we can go to the live sessions.
Yeah, we'll go to the live sessions, and we will start with intragastric balloon. So we'll just tell you in the short while. So we thought we have 2 cases lined up. One is a balloon and one is a ESG.
Thank you very much. We're really looking forward to it. Good morning or afternoon. Can you hear us?
Yeah. So we are moving on to first case for the live transmission. It's a 35-year-old female with history of multiple comorbidities and known uncontrolled diabetic with obstructive sleep apnea. Her weight is 82 kg with BMI of 31 kg per meter square, WHO class 1 obesity, and plan is to do an endoscopy guided balloon placement. Over to Dr. Nitin.
Good morning, South Africa. I am Dr. Nitin, and along my side, I have Dr. Santosh, who is my mentor on the side, and I have my technician, Mr. Naresh. Both of them having experience of more than 20 years in the endoscopic field. And for this patient who is having class 1 obesity, we are planning for intragastric balloon. This is the very special type of balloon. It is from SPATS 3. It's an adjustable balloon to improve patient compliance and achieve adequate weight loss. So for this patient, in the want of time, I have already placed the balloon on the scope. So we have this white color balloon facilitator, and this is the SPATS balloon, and along with there is a connector which can be used to either increase or decrease balloon volume in the follow-up as required depending on the patient's compliance and a weight reduction. So straight away we will proceed with the procedure. So this balloon is mounted on the standard endoscope, well lubricated with lignocaine jelly, and patient is under conscious sedation. So once I reach into the stomach, I will go up to the body of the stomach and then retroflex the scope to see whether I can see the lower end of the balloon into the gastric cavity. So there you can see now the tip of the balloon and the catheter is inside the stomach. So once we reach at this place, we'll just make a normal position and start inflating the balloon with the saline plus methylene blue. So for Indian patient, we initially put around 450 ml of saline. Balloon पीछे. So in the aliquots of 50 ml, we are slowly injecting the saline into the balloon. And for initial 3 to 4 months, we expect patient should lose around 9% to 10% of total body weight loss. If this has not achieved in first 3 to 4 months, then we call patient for follow-up at that point, and if this 9% total body weight loss is not achieved, we will inject 50 to 100 ml during next session to facilitate further weight loss. On the counter side, if patient is not tolerating the balloon at 450 ml, we can revisit by endoscopically, just take out this catheter out and again remove few mls of saline, either 50 to 60 ml, to improve the tolerance. But one should remember that as obesity is chronic and relapsing disease, patient should be continuously under follow-up with dietitian, physiotherapist and behavioral psychotherapist. A patient mindset determines if the patient will reduce his 12% of total body weight loss, or it can go up to 18 to 20% with intragastric balloon.
Nitin, if you can retrovert and show them, I think they can see the balloon.
Ashwin is now injecting.
Okay, right. So one more way of looking at how whether the balloon is getting inflated or not is you can retrovert the scope and then also, yeah, you can see here. Yeah, so that's one thing which you can do it. And the advantage of this balloon is that you have got that twig which you can pull it out and then adjust it whenever you want. So we usually in our unit practice off late only this kind of balloon. We used to have Orbera earlier, but this is now very advantageous because one is Orbera balloon, once you put it and then if the patient is not tolerating, unfortunately, then you have to remove it. It's all or none phenomenon. But in this, if the patient is not tolerating, you can just call them after 3 to 4 days, take out 50 to 100 ml, and then once they get adjusted to that, then you can reinsert 100 to 150 ml more. So you can do multiple sittings. And this balloon is a 12-month-old balloon. Otherwise, you can take it out after 6 months also if we achieve the desired weight loss. And the extended uses of this balloon off late, what we are doing is we are giving it, we are using it in our liver transplant patients, both in the donor and recipients, where for the recipients, our liver transplant surgeons want weight loss, especially in obese folks. So in that, we are using these intragastric balloons, very common. And also in the donor, where if you have steatosis in the liver and they are not eligible for liver donation, then we cut down, get the weight loss for them with this balloon, and then they'll be fit to donate the liver. So that's again one of the commonly used indications in our unit.
We are doing prospective study in patients with NFLD with this adjustable balloon, and we are half through the study, and we see that around 5 to 7% of patients are intolerant. Those required balloon volume adjustment. So now I have infused 450 ml. So I am slowly removing the scope. So this traction will help the facilitator to dislodge the balloon. At the same time, I am pulling out.
So can you show the hands of Nitin and the patients?
So now you can see the balloon has stayed into the stomach.
Satya, external camera, can you show them? How the endoscope is coming out and then how the tag is being catch. External camera. Satya? Yeah. You need to focus a little down.
Now you can see here.
Still down, still down. More down, more down, more down. Yeah. Yeah, as you see on the screen.
We have to catch it tight and put.
Yeah, so you see
put this lock so that the balloon is.
Yeah, just show them, Nitin.
Yes.
How you catch the twig of,
so this twig
lock.
Is,
yeah.
And I applied this lock, and this is tight. Now I am slowly relieving it. I will follow this endoscopically.
Yeah, you can leave it off. It's got elasticity, so
it
just
will go into
get
the
into
stomach.
the esophagus. Yeah, follow that and then push the white tag lower down into the stomach. Yeah. So you just have to push it from the esophagus till it crosses beyond the GE junction and leave it in the stomach. Push it down. So you have to just come back and then at the proximal end, you push it from here. You put your scope onto the white knob and then slowly push it down. Yeah, push it more.
So this patient will
that's it.
receive
Fantastic.
high dose PPI along with antiemetic for some time till the patient tolerates the balloon. So after this, I think we move to the next case, which is
Is there time for the comments or questions, or do we need to move to the next case?
so we are moving to the next case, which is endoscopic sleeve gastroplasty.
Dr. Nitin?
Yes.
You can take some questions. We have some time.
Okay, if there are any questions, we are happy to answer.
I don't see any questions on the chat. I just have a question. Are you ever worried about patients losing too much weight with these balloons?
Unfortunately, this has not happen with any of the patient, but we expect with balloon to patient to lose around 15% of weight by 1 year. And if patient is losing weight drastically, then I think we should look into other causes also.
So why I asked,
yes.
This was not part of our treatment of obesity when I did this kind of surgery, but saw a few cases where the balloon is not a restrictive device or a volume occupying device, but it becomes obstructive. So it would lodge in the distal part of the stomach and basically creates a sort of an intermittent gastric outlet obstruction, resulting in spectacular gastric dilatation and gastroparesis with the balloon sitting down in the pelvis, usually in patients that have had very, very good weight loss. Is that something that one should check out for? Is it not something that you see?
If anything that's can't be explained only with the balloon, I think we should look into other causes. Whatever you have experienced, I think this should also look into if patient is losing a weight with much higher speed than expected.
Okay, and then just thank you. And then just a very nice procedure, by the way.
Thank you. Thank you.
Wisdom Mudumbi again, how is the fluid volume adjustment done? That is reducing the volume via the valve. And then you also ask, where's the bleeding from that we saw on the endoscopy?
So this is some mucosal bleeding that usually occurs with few of the cases, but this usually settle on its own unless until patient is having any hemodynamical instability. We don't reintroduce scope to see whether there is any significant bleed or not.
And then just the volume adjustment, how is...
So the volume adjustment depends on the two things, whether patient is tolerant to the volume infused at first place or whether patient is achieving adequate weight loss or not. So if patient is intolerant, within few weeks, we can go back and remove 50 to 70 ml of saline from the balloon to improve the tolerance for the balloon. And if patient is not losing, we expect 18% weight loss at the 1 year. So we initially 3 to 4 months, we expect 50% of this should be lost. So if patient is not losing weight of more than 9 to 10% within first 3 to 4 months, we go back and infuse 50 to 100 ml of saline again at 3 to 4 months.
I don't see any other questions here. So if they're ready in the other endoscopy suite.
So we can, we can, Anirudh, can you project the next case, please?
Yes. We move on to next case. It's a 38-year-old male with recent onset diabetes mellitus, arthritis with obstructive sleep apnea, with grade 3 fatty liver diagnosed on ultrasound. Her current weight is 105 kg with BMI of 36 and class 2 obesity.
Okay.
Fibroscan showed a higher cap and 7 kilopascal on Fibroscan. She had failed dietary and lifestyle interventions and is planned for endoscopic sleeve gastroplasty. Over to Dr. Rakesh.
Thanks, Anirudh. So as you have seen, one of the gastric space occupying devices, now we'll show the remodeling techniques of stomach, gastric remodeling. So as you see on the screen, you have seen the history. What I am using now is a Apollo overstitch device from Apollo Endosurgery. So this is a suturing device which comes with couple of components which one has to understand. And as you see here, there are 5 components which are very important. Satya, can you play the video there so that they can have a parallel view on the animation also? We have the handle of the handle which is used to load the sutures and cinches. And then you have the helix which is used to draw the tissue when you wind it. I will show it to you. And then the third component is the anchor exchange which you see on the screen. Can you show them outside also? That is used to load the suture and then suture the mucosa and again reload the suture back. Then you have another component which is important is the suture which is made of polypropylene. This is 0.5 suture from the endosurgery. Can you show the suture box also to them? So this is how the suture looks externally. And for every one of round of suturing, we use the suture and then cinch it. Then you have the fifth component, which is important, is the cinch. So anyway, I'll just go on and then start the procedure and show you how it looks. So as you see here, for want of time, I have loaded the suture and then got ready. So what we do typically is we start from the incisura of stomach and then go towards the posterior wall. So that is, incisura of stomach is the anterior wall. As you see here, I'll show you. This is the incisura, and this along this line is the anterior wall. Then this is the greater curvature of stomach, and then this is the posterior wall. So we start suturing as a U pattern from the anterior wall, then take one on the greater curvature, one on the posterior wall, come back, posterior wall, greater curvature, and anterior wall. So as I start now the first suture, which starts from incisura, what I am going to do now is I have already loaded the suture for deploying. So this is the helix which is moving on your screen. So helix out. So what I'll do is I have got Naresh to assist me, and I've got Dr. Harnath and Dr. Santosh, who are experts in this bariatric endoscopy field. So the patient is basically intubated under general anesthesia, and now I put the helix down into the mucosa. Can you rotate? Okay. So once the helix is inside and then grabs the tissue, I'll just gently push the tissue into this, between these two towers, then close the needle driver. And once the needle driver is closed, next step what I'll do is I'll transfer the, you can see my hand movements. I'll transfer the suture, and then once the suture is transferred, I'll get a click kind of feeling here. After that, I will unwind the helix. Right? Okay. So once the helix is inside my scope, then I'll open the handle. And as you see here, the first suture is deployed. Can you see it's a transmural suture? So I'll just try to detach myself from the mucosa. You see here, the first suture on the anterior wall at the incisura is deployed. Now I'll go to the greater curvature, and before going to the greater curvature, again this is the steps what you have to follow. You go back, the anchor exchange is taken inside the scope, then you load the suture as you see here. Now the second suture, I'll go to the greater curvature of stomach and start deploying it. Helix. So you can see the animation, how it is done. I thought we'll just enlighten you with that also. Same step. You see here, second suture on the greater curvature is done. So now I go back to posterior wall, then take the third suture. Before that, again, I'll take the exchange inside. Reload. Third suture, which is going to give a semi-circumferential coverage of the stomach at the dura head. Now again the third same step. Helix inside. Now detach your scope from that. So as you see here, I created a circle. Can you appreciate there? So now what I'll do is again reload the suture. Go back to the posterior wall. Go 1 centimeter below the previous suture. Take the mucosa there. So as you see my hand movements, helix out. 1 second. You see my hand movements, you should have a little flexibility. Yeah, one more thing I forgot to mention is I'm using a double channel Olympus endoscope, which is must for this, because you need 2 channels to get the
mount the overstitch device. Take here. There will be a little bit of blood being oozing out, but we should not worry about, because suture itself will act as a tamponade, then achieves the hemostasis.
Do you not use APC to pre-mark the stomach?
Yeah, I used to initially, but off late I stopped. But some people do use it as a mark to, have a clarity on where to suture. But it's like, probably once you are initially in the learning curve, we use, but off late we stop. Not very soon. But you are right. Actually, that's one thing which most often many of the folks across the world they use. Now I have finished the posterior wall. Go to the greater curvature.
Are you using 3 sutures to bring it across, or are you going anterior, posterior wall with nothing in between? Just to take off the tension, I'm just asking.
Yeah. So I am using the anterior wall, greater curvature, and posterior wall. Three places, 3 sutures. So it's like a U. It's like a U pattern,
More or less, how long does such a procedure take you? You're obviously very experienced in this.
So we usually take around 45 minutes. Most of the procedures get along, unless the stomach is very big, where we need to probably, most of the times, we actually do around 5 to 6 sutures, but sometimes if the stomach is big enough, we might end up doing 8 and 9 also. 5 to 6 is standard number what we quite often. So I am going to the place where I started on Sura, then take the mucosa there, okay? Here I have gone to the incisura again on the anterior wall, then finish the last round of suture. Helix inside, helix inside. Now you see here, I'm done with the first round of suturing. So what I'm going to do now is take out the helix and then deploy my suture here. You can see a T tag comes out here. So now that is done. So now the very next important part of what I want to all of you to see is, as you see here, I am just giving some traction on the suture here, and you see the whole stomach mucosa is getting dwindled into that place. So the next step what we're going to do is, I leave the suture here, of course, after cinching it. Cinch is another important component which you have to see. It acts as a knot. The cinch is mounted on, railroaded on this suture. Once it goes into the mucosa, this part of the tip will penetrate into the mucosa. I give traction so that there will be good amount of tension around the suture. As much as possible, the gastric mucosa comes in and forms a tubular kind of structure. As you see here, he is loading the suture onto the cinch. Do it. This is a little important and careful step, one which you or your technician has to be a little well versed. Initial stages, you end up sacrificing some of the cinches and sutures. So it's a little costly mistake what people tend to do. So as you see here on the screen, endoscope on the external camera, I'm putting in this cinch inside the double channel scope. Position myself here. You see, tip will come out. Once the tip comes out, give it. Hold the suture a little bit, not very much. Yeah, as you see here, the cinch is going to be put deep into the mucosa, and what I will do is I can concentrate on my external hands. You see, I am binding the suture, and I just want to show you how much amount of tension you can give, and really a transmural suturing. So as you see here, giving traction and trying to give as much of tension as I can. if you can observe my hands, I'm leaving the scope in the air. So literally, that's so much of traction is being given for the suture to give a good transmural tension. And as you see here, what I'll do is I'll push the cinch simultaneously with the left hand giving traction to the suture. And you see here the cinch is out. Okay, cinch it. Yeah, just show him the hand there. They're showing it. Yeah, put it back. Yeah, both the hands. Press hard the. Yeah, just press. Okay. Now, as you see here, cinch is done. Can you appreciate there? The first round of suturing is done. So what I'm going to do now is come back and then start the second round from here. So you see here, there's already a tubular kind of structure which is being formed at the antrum area. So in this way, we start and then ascend upwards 5 centimeters below the G junction and then stop it so that the stomach will become a tubular organ. So we can take questions on this. Nitin also is with me, who can help you out for any queries on this. In the meantime, as I told, this is something like a surgery which will take half an hour to 45 minutes. So I keep on doing it. And in between any questions, me and Nitin will be happy to answer.
I might just ask a question, Rakesh. The depth of that suture that you place,
yeah,
does it incorporate the muscular layer as well, or is it basically mucosa and submucosa?
Yeah, very good question. So what we typically see, even in the animal experiments done earlier before this device came into, is that it will usually, it's a transmural. So mostly it will hit the out. Go back. Yeah, sorry. So what it's a transmural, but typically it will hit up. It will go up to the third and fourth layers. Helix out. I want to start where I helix out. Wait. Yeah, sorry, I think I answered your question. Or
so there are few reports which have described gallbladder perforation during this procedure that indicate sutures are transmural only, and unless you achieve a transmural suturing, the permanent reduction or the prolonged weight loss for a longer duration could not be achieved. So the primary aim to place all the sutures as transmural sutures only. So to see that whether your sutures are transmural or not, one should make attempt when you are winding up the tissue with helix. You should make around 4 to 5 winds so that the adequate amount of tissue is along the helix, and followed by when you are doing a tissue bite. Now see at this point, if you are catching a lot of tissue between two towers of the device, then the sutures will be a transmural in nature. And once the both layers of serosa are outside the stomach are getting contacted with each other, that will cause a fibrotic reaction in the serosa, and that will lead to a gastric cavity volume reduction for a prolonged time. So the placing transmural sutures are most important thing for this procedure.
okay, so now
I just want to ask another question. One of the concerns of the laparoscopic sleeve operation was that if you actually take away part of a normal stomach, and that you won't be able to reverse that, as opposed to most of the other procedures that you can actually, at least anatomically, reverse. Is this a procedure reversible? What happens if you cut those sutures?
So that I think is an extension of the first question, whether the sutures are transmural or not. The reversibility, if we cut the sutures just within 1 week or two, then there won't be a fibrosis of serosa and the procedure will be completely reversible. But once the fibrosis has set in along the serosal side, I think this will be this can't be a completely reversible. However, the sutures can be cut from inside to remove the sutures. And we personally have not done any of this procedure to reverse the thing, but those patients who subsequently required surgical intervention in many of the series, the technique for laparoscopic sleeve gastrectomy or other bariatric surgeries has not changed. The same techniques can be utilized if patient required additional therapy with the surgery also. Sometimes those patients who required re-intervention, that's redo ESG, some of the sutures can be removed if they are coming in the way of the resuturing. Otherwise, removal of suture is not required.
Yeah. Yeah. Need helix out? Okay. Fine.
Just one more question. We know when we do vertical banded gastroplasties, one of the failures of the operations are when the taper line actually hits, and that you get another opening to the distal part of the stomach with the band in place. What happens here if the top suture gives way? Is there recanalization of the created tube or not?
No, there won't be any recanalization. Only thing is, once over a period of time from past 4-5 years, what we have experienced, once the sutures start, the dehiscence happens, there will be a little bit of increase in the volume of the stomach typically, and then at that point is where, like your sleeve gastrectomy, the residual stomach will start expanding if the subject doesn't stick on to the dietary habits.
So just a follow-up question there, is it possible to do a re-endoscopic sleeve?
Yes, we can. It's doable. Only thing is, you have to probably spare the areas where the suture has already been deployed, because there will be some amount of fibrosis, and the non-sutured areas you have to target and then try to resuture them. Yeah, out. Okay.
There are also a few questions on the chat now.
Yeah, please.
I understand you're concentrating, so just answer when you feel comfortable. Is there a possibility of sutures dislodging and dehiscence? I think we've addressed that. Is there complication of gastric ulcer? Is there complication of gastric ulcer? And do you routinely check for Helicobacter pylori before this procedure?
That's a very good question. Actually, H. pylori, in fact, in Indian population, H. pylori is a common commensal. So we usually do it when you have a high index of suspicion, a strong family history. Yeah, a strong family history, or before procedure we do a meticulous endoscopy with the NBI also, narrowband imaging. So if you have any high index of suspicion, we do rule out H. pylori and do it. Fortunately, the incidence of gastric cancers is not that as high as in the other parts of Asian countries. So in that way, we definitely look on that, but that's not a real hindrance for us to stop it.
So long back we have done study on the H. pylori and the gastric and the duodenal endpoints for this in Indian and Nepalese patients, and we found that the phenotype as compared to the Japanese, in Indian and Nepalese population, the phenotype is more of duodenal ulcer and ulcer related bead rather than gastric ulcers or gastric malignancy in our patient. Till if the patient is having history of CA stomach and patient is having active gastroduodenal ulcer, we always rule out H. pylori by doing a standard investigations and treatment. The presence of active gastroduodenal ulcer is actually a contraindication for this procedure, and one should treat for all the risk factors for gastroduodenal ulcers and then only proceed for this procedure.
Right. So I am now. Yeah, please go ahead.
Another question from Wisdom Matombi. Do you give these patients antibiotics before the procedure? And are they routinely put on a PPI afterwards?
Yeah, so that's a very good question. So all our patients who are undergoing this endoscopic sleeve gastroplasty, they will be given a shot of dexamethasone. Even for that matter, the balloon patient also, is because the tolerability and the anti-inflammatory effects of steroid is good. So they will invariably on the steroid one shot, and apart from that, as you have mentioned, we'll give one shot of antibiotic pre-procedure and one post. Apart from that, the proton pump inhibitors, one second, and antiemetics, which includes ondansetron. Yeah, Finch.
And then just a question from Manoko Siabi as well. Is the tip of the sink connected to energy, or do you just twist it into the mucosa to grab the suture?
Sorry?
So I just hope I understand the question correctly. Is the tip of the cinch connected to energy, or do you just twist it into the mucosa to grab the suture?
Helix.
Yes, we put a traction on the suture using one hand and push the cinch device deep into the mucosa so that there will be a proper approximation. And then we cut the cinch using this device, cincture device. So there has to be traction from one end on the sutures and the pushing of the cinch device into the mucosa. So that has to be done at the same time so that the approximation of entire gastric wall has happened.
Yeah. So Satya, I think in the meantime, we'll take another probably 15 to 20 minutes to slowly ascend up. So Satya, if Dr. P.N. Rao is ready, what we thought is we'll just go to Dr. P.N. Rao's lecture on the ethics, medical ethics, and then come back to you. By the time you come back, probably we'll be almost done with the suturing. So over to Dr. P.N. Rao if he is ready. Satya? Is that okay with you guys?
I think that's perfect. That was more or less how we planned it. So thank you very much, and we catch up with you a little bit later.
Yeah, we'll come back to you in a short while after the lecture.
So we're going to move on to the ethics lecture, and I think this is a very important lecture associated with this kind of surgery, especially in the era before we realized the metabolic advantages of it, when it was regarded still very much as a cosmetic procedure. So it's a real to introduce Dr. Rao. Again, a very, very long CV, very impressive. But just to summarize, he's a distinguished scholar and teacher and innovator, and served in on many of the professional organizations and societies in a whole range of capacities. So, Dr. Rao, we're really looking forward to your talk. Thank you very much.
Thank you very much. Good morning, Africa, and then good afternoon here in India. It is PM here. Me great pleasure, and also consider it a privilege to share with you some of the thoughts about the ethical ethics which concerns all of us. Many thanks, Tejas, for giving me this. Very much. Well, we all know, how we started our medical and profession. But what has happened subsequently, many of us not have followed, been the very specific regulations, specific ethical considerations, also in flow, there's not been amendments been made, understandably, flow of the time and also administrative necessities in any particular country because specific. To give you a brief idea how the on see here time frame in which modifications made, and on the left hand top corner see the Nuremberg Code in 8, also the government, the Declaration of Geneva has been adopted in 1948 but been amended several times, 8, 95 and 6, and it requires the declaration of the petition's dedication to humanitarian goals. People being associated with research, read an article, any kind of an article, one word would be has been taken care of, Helsinki. And the brief of the declaration of the clinical research trials is the well-being of the human subject take the over the science and then society, and of course consent in writing nowadays, of course, video consent taken, and you have to use caution. Participant in a different relationship and limited use of participants. And the major thing which has happened is the International Code of Medical Ethics in ethics given by the World Medical Code applies both peace and then war, and then codifies the duties of the physician in general, duties to the patients, colleagues. And then we in India, we have our of course, it's interesting to see this also in present both. And this is the ancient Ayurvedic guide, physicians in India, writing here, called the Charaka Samhita, just to be read. And well, then this is the what we have already taken an oath, and let me tell you, concentrate on this. There have been a lot of obviously going, teach them this part if they want to learn it. We are indentured. Perhaps is patient and will not give a woman a pessary to abortion. But in medical any country, still abortion is. And last, see here, if I carry out this oath, break it not, may I gain forever reputation among all men for my life and my art. But if I break it, forswear myself, may the opposite befall on me. Why I emphasize is that in those times, it is conscience. There is no other regulation regulatory bodies. It is the personal conscience person that is giving the dedicate what he has to give. Left-hand side, you are seeing the World Medical Association. Read it, and it is rather the as per the current practice. One which is very particular is that I will not permit considerations of age, disease, disability, creed, ethnic origin, their own intervene between my duty. This was called an Hippocratic oath, way printed in a way, like the case of the World Medical Statement pledge. On the right hand side, you can see here that the South African person. Well, then, with the times changing, the recent times, the medical ethics has been greatly influenced. In a pluralistic and multicultural world, many differing moral traditions, major international rights agreements can foundation medical education and culture to have. Common, of course, medical ethics is all. And most of the medical license can and do punish physicians. Only that, it quite often expresses higher standard behavior than does the law. Occasionally, ethics require that the physician disobey the laws that demand ethical behavior. Means that, to give you an example, there has been an accident. In many countries, this or first register the case and then bring it. But then by the time the lot of loss of time is there, in some places, the clinician does not treatment, yes, the live on this. Which case, clearly, law and the ethics clash, and naturally, the standard treatment for any of the any other. Also, the law differs significantly on country, while ethics is applicable. Then legal obligation. And you can see that the medical ethics law are not the same, but often help. Means that they are intertwined, they are interdependent, but at the same time, they are independent. And breach of the ethical obligation may not necessarily mean breach of the law. As breach of ethical obligation may be used to prove the medical negligence. Most of the countries. Basically, we got only three types of ethics. One, medical ethics, where we have a clinical obligation in terms of professional ethics, that self-regulation and education of ethics. Bioethics, that gene technology, health system. And what are the basic components? Basic components: triangular, physician, physician relationship, and the relationship healthcare exists. In some countries, healthcare state itself subjects. Relationship of the basically physician to the society. Basically, the ethics in the overview, basic principles of the ethics, that one is an autonomy, beneficence, non-maleficence, justice. These are the pillars of. What are these? These, there are six are there, but these four. One is an autonomy. Patient has right to refuse or choose. His essence, practitioner should act in the best interest. Third one is important. Not do good, don't do bad either. Non-maleficent. First do. And is not only more important to do no harm than to do good, it's also important to know how likely is that your treatment is done. And one yes, likely is that. And justice, concern that justice basically also, and the other the features which are there existing in the particular country concern the distribution of the scarce health resources and the decision as to who gets what treatment. And dignity, of course, both the patient and also the person who is treating the patient have the truthfulness, and then honesty, of course, depends upon the conscience of the individual. And basically, the informed consent has increased the importance in the historical events of the doctor's trial of the Nuremberg trial and Tuskegee syphilis study. And in the Tuskegee syphilis study, as we know that, patients in the natural history of the syphilis. I will not go into the details of this one. One can see it. And of course, it's very important to have a compassion and then the competence and the autonomy, the medical. And these are all what I have just enumerated, but in a more descriptive way. I will not read any one of them. And then you can see here on the right side that the competence of the medical care, respect to the human dignity. And they have to uphold all the standards of the professionalism, respect the law, and respect the rights of the patient, colleagues, not only patients, colleagues, and other health professionals who are working with us. And of course, shall continue to study, apply, advance the scientific knowledge as what is been happening just now, is in terms of our CMEs and then in terms of our workshops as to get themselves updated. And the responsibilities of in activities contributing to the improvement of the community. We have got a responsibility for the community. We have seen recently the amount of responsibilities which for all over the world, because of the infection of COVID. But then sometimes we get confused many times about the truth. Doctors always tell the patients their diagnosis. This again depends upon the cultural and also the societal norms in that particular country. Then suppose sometimes malignancies, HIV, dementia, psychiatric diagnoses. These are sometimes whether we should tell directly to the patient or not, or if the relatives, they ask the doctor not to disclose the diagnosis to the patient. What we should do at that particular time, should we just take the word of the relative and then not tell, or tell the patient that they are suffering and then further, they will go into further depression, and that will also be not ideal for the management of these patients. And also sometimes in some of the countries, especially psychiatrists, going to a psychiatrist is considered to be somewhat uncomfortable feel, and tell that I have gone to a psychiatrist, many people don't like it. And in fact, in some of the countries, the psychiatrists, they write the neuropsychiatrist, so that it will the attract and then the neurological connection is also there. And sometimes the patients the attendants come and tell us that when the psychiatrist comes, he shouldn't tell that he's a psychiatrist. He must just examine the patient, make his diagnosis, and then prescribe and then go. And to this extent, and then these are some of the places, where there is whether it's a conflict of interest, or whether it's a conscience, or whether you are doing good to the patient by acting against your conscience. These are all some of the ethical questions related to the ethics and then our own conscience. Well, then informed consent. In the informed consent, what constitutes an informed consent? This is especially for various invasive procedures and also for the clinical research. The information to allow a reasonable person to take a decision, and they have to completely understand, comprehend, and then information given. and there should not be any coercion or incentive to accept or deny the treatment. And the verbal or written or sometimes nowadays the video counseling, and then it is done to be discussed with the interventions. But many of the times, it also depends upon the patient's comprehension, patient's educative capacity, and then what level they are educated, how much we have to tell them about this one is also a big question. Sometimes, many times, the consent form is given to them and they sign it and then give it to you. But there it is our duty to inform them in their own language and go to their level of their comprehension and explain to them in writing and with preferably with the diagrams, as what is going to be done and then what is likely, what is not likely, what are the likely implications and then complications. Well, then this is again another issue that, when somebody comes to us and then tells you this, and some people tell, oh, it's done like this, or done like this. Some of the things we express that, this kind of a thing. And you can see that in much wisdom is much grief. That means that if you become more wisdom, there is a more grief. He that increaseth knowledge, increaseth sorrows also. For this is relevant to this particular situation. Well, then patients are now, they are quite demanding, and also they are going and then going to Google, and then all information is available with them before them, and then they offer Googlies to us. And also, when we speak to them, we should speak in a language they can understand and comprehend, because by just going to the Google and then getting the knowledge, most often they are confused. Also, it is our duty to see that all their doubts and then they are cleared. And then what is written in the Google is for the general public, general overall for everyone, not particularly to the patient concerned. Well, then the medical ethics in the time of the COVID-19, and I have been tempted to quote this French surgeon Dominique Jean Larry. He was the first to establish the medical sorting protocols in the context of the battles of the Napoleon Wars, for which he used the word triage. We are now using the same thing, meaning sorting. He articulated 3 prognostic categories. I think this applies very much to COVID situation and where the ethical concerns come into view. Those who would die even with the treatment, those who would live without treatment, and those who would die unless they are treated. So the triage decisions arise in the context of insufficient resources, particularly the space, staff, and then supplies. I think I don't need to emphasize this. Every country, every place has gone through recently these things. There, the ethical questions would come, that especially the first one, what are we going to do? Then would you do it at the cost of another one who is the younger and then who requires? I mean, these are all they go to the according to the situations, one has to go. Then again, when somebody is COVID positive, whether he has to inform or not, whether somebody has to inform or not, in the light of that one, in very early in 2022, and the novel coronaviruses, there was HIPAA privacy and the novel coronaviruses in the USA. And in the African countries, as you can see, the ethics COVID status disclosure to tell or not to tell. On the right-hand side, you will see in the Nigerian proponents of the COVID-19 stated disclosure opine that the public interest overrides any issues of the individual privacy. Although the section of the Nigerian Medical Ethics Code say that disclosure of information on the patient by the doctor can only be made following the informed consent of the patient, preferably in writing. But there is a caveat here, excluding the situations in which the discretionary breach of confidentiality is necessary to protect the patient and the community from the danger. And therefore, there is certainly a need to have balance of the individual privacy and the public safety regarding the disclosure of the COVID-19 status. And this is quite interesting. On the left-hand side, you see the deontological, and the right-hand side is a collective and then utilitarian. The left-hand side is about the individual patient ordinary medical practice. On the right-hand side, what we have seen in the recent last 1 year, the disaster medical practice, the collective, that is the utilitarian. You can see here that the assessment has to be quick on the right side, quickest the first third, and follow-up is limited in this particular one, then limited and then depleting resources are there, and need for the non-traditional extensions, as you know, that the hotels, firehouses, schools, wherever there is a space have been used as the COVID hospitals have been maintained. And also at that particular point in time, because of the overwhelming cases of these, there have been a temporarily shut down for the new cases and also some of the follow-up cases. Some of the follow-up cases we know, I mean, everybody knows that what has happened to them because they could not be hospital. There has been certainly some of the things were according to as per it should have gone them. And of course, the last one is again what we have seen, that the protests which are occurring in various countries. The lockdown, that is a general lockdown, but this sometimes refers to the hospitals that are overcrowded. So the bottom line is that, of course, we are coming to end up a COVID, hopefully, the cases because of the vaccine and then the herd immunity or whatever is there. But certainly this has given some kind of an indication about an increased attention to prior the ethics and then equity ethics and coherent national and then international agreement on how to best deploy the limited supplies such as the ventilators and then protective equipment. Well, then one commendable thing which has happened is that across cutting all the, whether it is a party, whether it is a societal status or whatever it is, politicians, actors have come in a very, very big way in disclosing that they were affected with the COVID infection, and also giving a caution to the people who have been recently in contact with them should get tested. And this is one of the things which has happened globally across all over the world, irrespective of the country, religion, or creed. And then coming to the research ethics, I will not go into the details, but suffice it for me to say that every country has got their research ethics by their own medical councils. And we have an ethics committee, and then in the ethics committees, we have only the professionals, the doctor professionals, we have philosophers, lay people, and clergies. And in many parts of the world, their presence is considered is mandatory in order to provide a balance. Then the last two contain the futility. And the concept of the medical futility has been an important topic in the medical ethics. What should be done if there is no chance that a patient will survive, but the family members insist on advanced care? Previously, some articles defined the futility as the patient having a less than 1% chance of surviving. But who decides this 1%? Whether that 1% is the standard, how standard it is. And some of these, of course, land up in the courts. And some of the things which can be done is in advanced directives, including the living wills. And also in many cases, the express wishes of the patient are documented in these directives. And this provides a framework to guide the family members and the healthcare professionals in the decision-making process when the patient is incapacitated. Euthanasia, again, this is a subject of a very controversy. Some of the countries have adopted it, but some have not adopted it. And on the right-hand side, in India, we had a case in 1973, junior nurse in Mumbai, and she was assaulted, and she's been a vegetative state since the assault, that's 1973. A plea for euthanasia was filed in the Supreme Court by one. And after 37 years, after she had been in the status for 37 years, the Supreme Court of India responded to the plea of euthanasia, and the court turned down the mercy killing petition 21. And therefore, the debate on the passive and then active euthanasia continues. This is a very, very sensitive issue. And this is country specific. Well then, ladies and gentlemen, this is my last slide, and then I can only say what is ethics and summarize in a group of moral principles and set of values that define or direct us to the right choice. With all, I could say that this depends upon our conscience. The lower one, that is ethics, is knowing the difference between what you have a right to do and what is right to do. And thank you very much for your attention. And I hope I have made conscience open and then gone through these medical ethics. Thank you very much.
Dr. Rao, thank you so much. That was a really interesting talk. I actually liked how you summarized and you built it up from where ethics started to where we are currently. And I actually enjoyed the last bit of your collective ethics in a disaster situation, and there's still ethics that have to be applied even in this situation. And I acknowledge how you brought it up into COVID, because I do think lots of ethics and rules and regulations are being bent in a way regarding COVID, and it's a good reinforcement for where we are now. I'm just going to take some questions before we go across, and if they are ready for us to go across to see the live procedure, we'll go through. But I'm just going to ask you one question from Dr. Mudumbi. Is it ethical or professional for medical aid societies or insurance companies to ask for endoscopic reports with all photo documents? As some endoscopists don't intubate, I assume the terminal ileum. He says seek them for reimbursement.
Well, for these things, that's the reason why all the procedures of these things have been elaborately. They are present in the presence of the nurse, and then it is known to what exactly happened, and then what is going into the reports. Everything, I feel that everything depends upon the personal conscience level. As far as the rules and then regulations, then we have all kinds of restrictions and also the SOPs which have to be followed in that particular country as far as that procedure is concerned. Because in some of the countries, then you just write one single page report of an endoscopy, say the esophagus, stomach, and duodenum. But in many of the countries, you are supposed to start from the start. You are supposed to do, and most of it, of course, it is already been there in the only small necessary changes have to be made. That particular.
Thank you so much, Dr. Rao. Are there any other questions? Please don't forget to put your your questions onto the chat. We're just checking to see if we are ready to go across to the endoscopy room, and we're welcome to take any more questions throughout this. Dr. Rao, again, thank you so much. I think we're living in challenging times with the COVID, and okay, we're back at the endoscopy, Dr. Rao, so we're just going to rejoin the endoscopy participants. Thank you so much.
Thank you.
Oh, hi everyone, welcome back. So as you see here, I have finished the last round of my suture. We have deployed 6 sutures in this patient, and you see there is a kind of a tubular structure what stomach looks like. I'll just wash the area and then so it will be clearly visible for you. A little bit of blood ooze in this procedure is very common, but it is very self-limiting. As one is, of course, you have to be careful that the patient is not on antiplatelets. And the suturing, when you do, the ooze, what happens when you tension the suture and then cinch it, that itself acts as a hemostasis. So I'll just show you where we started. I usually, most of the procedures, we don't go in back because that I won't want the stomach to get inflated. So roughly, as you see here, I'll just close my suture, the device, and then we started somewhere here in the antrum at the incisura, and as you see here, there is a neat tubular structure. The stomach, the whole stomach is shrunken now into a kind of a tubular structure. As you see here, I am trying to showcase you. This is that's where we started, and then this is the 6th suture where we placed. I'll come back and then show you. Let me clean this area so that I'll try to locate the G junction. Okay, so now you see here, this part is sutured. We purposefully leave the fundus because it is a blind procedure from this end, as fundus has got a lot of short gastric veins. Unlike the sleeve gastrectomy, we don't do any suturing in the fundus. So fundal sparing is mandatory, and once we come up to the fundus, that is around 5 to 7 centimeters below the G junction, we'll stop suturing, and then we will call it end of the procedure. So can you appreciate it on the screen? As you see here, can you appreciate it?
We see it very nicely. Thank you.
Yeah. So what I'm going to do now is I'll suck out all the air inside. And before that, I make sure that it is closed because it should not rupture. And one more last point, what I want to show you is, can you show them the mouth of the patient? So this particular device has got a over tube, which you can mount it, and that itself is act as a gag. You don't need to put any gag otherwise. Can you just a little forward? Or you can show the over tube outside. So this is the over tube which is used initially to intubate the patient. And thanks to our anesthetist who has got a vast experience in bariatric endoscopy, so with their help, the patient from past 45 minutes to 1 hour is completely sedated. There's no movement. And of course in GA, and this particular over tube acts as a gag to intubate the patient. So I'm taking out the scope, and then after that I'll remove the over tube. So this is the end of the procedure. Post procedure, some things which we have to be very careful is, as I told you, intra-op, we will give dexamethasone, antibiotic, anti-emetic, and one analgesic if required. And after this, the very important thing what we have to follow is a protocol of diet, which is very important. First week, the patient will be only on liquids because you need naturally to accustom to this small stomach. Second and third weeks, it will be a prune diet which contains thick liquids. And fourth week, we will come on to the natural diet on a low calorie form. So this is very important in the first 1 month for the patient to get adjusted to this new anatomical stomach. And we will mostly, this is 2:30 here in India. So probably tonight or tomorrow morning, we'll discharge the patient and then follow them up on OPD basis. And our nutritionists, clinical psychologists, and physiotherapists will be constantly guiding and monitoring the patient wherever they are across the world, and then keeping them motivated. Because as it was rightly pointed out earlier by one of the panelists, it is very important to motivate these patients and keep them driving on the motivation to get weight loss and sustain the weight loss, which is very important. Naturally, they'll get weight loss for sure for 15 to 20% in the next 3 to 6 months. But as I told you, the suture dehiscence might happen in a long run after 2-3 years, and that's where they start eating again. So that mindset should be very stubborn, and then they should have a good willpower.
Thank you very much for this absolutely fantastic case. Really well done. I think that the questions that were posted on the question list here have been answered. It was the proximal extent of the suturing. I just have one question in general regarding these procedures. So if you go back to the pre-gastric bypass era, when we basically did restrictive procedures with a BBG and then a small bowel clear, only small bowel bypass, there were efforts to select the patients in terms of their eating patterns that never really sort of resulted in any good guidelines. Do you think, so in the era of personalized medicine, that there will be at least guidance of which of these procedures may be most appropriate for a specific patient? And then also, how far are we from maybe society endorsed guidelines for these new treatment modalities?
Yeah, in fact, if you come to the last part of your question, the guidelines have been already formulated. There is a Brazilian consensus and there is a US consensus which has been published in the recent journals. But if you ask me in a typical clinical practice, what I choose is about the patient being motivated. So you can easily pick up when you do a clinical history and examination in your OPD in the office, whether they're really motivated or not. So what I feel personally is if it's a motivated patient, and of course, if you're treating a standalone obese or standalone diabetic or obesity with diabetes, that again depends on what procedure you choose. And typically the bariatric endoscopy guidelines say any patient who's got BMI up to 40, that is 27.5 to 40, or the ideal patients to take up a bariatric endoscopy. Whereas surgery again it has got a wide range from class 1 to class 3. So the patient motivation is, of course, and it's not that every patient who says I am motivated will not sustain that motivation. But again, there are specific guidelines which are published in the recent GIE and also in the endoscopy journal, where we have come up with the guidelines. In fact, the International Federation of Surgery of Society of Obesity Surgeons, if so, there is an endoscopic chapter now being started, and we are coming up with those specific guidelines for patients who will fit into bariatric endoscopy probably in the next couple of months. So that will give us a clear demarcation of whom to choose and whom not to choose.
Thank you very much. I don't see any more questions. So if there are any more questions, I think it's over to you, Adam.
Thank you, guys. Thank you so much. That was most helpful and insightful, and your technique and your speed was amazing. I know there are 1 or 2 people doing this in my town, which takes on average 3 hours. So you've just highlighted that we shouldn't be afraid of it from a time point of view. Thank you so much. From a technical point of view, your assistants and all of that, are they all trained with you as a team, or is the training process done separately or whatever? How does it work?
No, the assistants over here are trained with us, but in fact, from past 1 year before COVID, we trained around 400 endoscopists across India and Asia on a hands-on model in our wet lab, on a porcine model. So most of the endoscopists who are pursuing bariatric endoscopy, they had a hands-on of course on the animal models, and then we do keep on doing it. Once now the COVID is ending, we are planning to start a focus group of courses on this hands-on training, along with a live case and some lectures, which we will commence from April this year. So I personally feel before going on to the human model for suturing, you have to have a hands-on training on the animal model, which will give a very good experience on that, how to do. Because as you see, this is a very costly affair. And once you start on Apollo overstitch device, you tend to lose a lot of sutures in the initial part, which probably you yourself or your hospital will not afford to or won't allow you to do. So if you do your training on a hands-on model, on an animal model, and then get on to that, that will be easy. And in my experience, the learning curve is around at least 15 to 20 cases, Nitin?
Yes.
Yeah, 15 to 20 cases should be a learning curve. But once you get the rhythm of these steps like a dance, then you'll never forget, and it'll be easy for you to go forward.
All right. Thank you so much again.
Yeah.
So I think we've come to the end. Sorry.
Yeah, I take this opportunity to invite all the endoscopists across South Africa in this hands-on training, which we'll be commencing on from April 2021. And we will be in touch with your society heads, and we will post you when we can apply and then when you can come down for this training.
On behalf of SAGES, on behalf of South Africa, the surgeons, the gastroenterologists, and also I would like to say thank you. I do believe that this is a fruitful endeavor, and we're probably going to make this something going forward. I should have mentioned Dr. Reddy was with us in 2015, and he gave the eponymous lecture for Solly Marks in 2015, Frontiers of GI. And 5 years later, he and his team, including all of you, are showing us what can be done, what is being done, and how we're going to learn from you guys. And with sincere humility, I thank you guys for the time out you guys have taken out on a Saturday, odd times, to the AV of your AIG Institute, who's run a flawless 2 hours, 2.5 hours with no hiccups, which is unbelievable. I must thank each and everyone in the back that are behind the scenes, all your assistants, your technicians, the anesthetists, your sisters, and most importantly, the patients who are allowed and consented to be part of this year, and all the speakers, and also to Prof. Jonas for being a participant and chairing the session on a Saturday. And we hope to take this further. And lastly, to thank Sun Pharma for nagging and getting us involved with this eSPACE program. And I'm going to turn over to Sun Pharma to give the last closing remarks. And good day and goodbye, and thank you again. It was a pleasure.
Good afternoon, everybody. I'm Peter Walton from Sun Pharma, and I would just like to thank Dr. Reddy very much, as well as the AIG facility team, for this insightful and education presentation, as well as these live webinars, workshops that took place. Once again, thank you, Prof. Jonas and Prof. Mohammed, for chairing the webinar. It was really much appreciated. We couldn't have done it without SAGES and without your help. Then also I would like to thank all the attendees that RSVP'd and attended the webinar, as I'm sure that you guys have learned a lot out of this webinar. And if you could kindly complete the post-event feedback survey that will be emailed to you in the course of next week. And then lastly, but not least, I would really like to thank all my fellow colleagues at Sun Pharma for making this webinar happen, and for all the hard work that went on behind the scenes for this. Thanks once again, everybody involved, and have a great weekend. Thank you.
Thank you.